Good afternoon, everybody. My name is Mark Sickles from the 43rd District, which is in southern Fairfax County, Virginia. And this is the first joint oversight subcommittee we've had in a while, and I'm looking forward to this. This topic got a lot of attention over the last couple years, and we were going to have a meeting covering this during last year, but COVID interrupted. And ironically, this is a hopeful statement. I heard that there was some progress with the agencies and the providers to get on the same wavelength, and some policies have been developed. I'm hoping to hear about that today, where we've got some more uniformity or agreement on what we're doing and how we're providing these services to the public. But we're going to start today by introducing ourselves and where we're from. If you don't know, we'll start with my good friend, Senator Adam Ebbin, who is my senator, by the way.
Thank you, Mr. Chairman.
Yeah.
I'm Adam Ebbin. I represent parts of Alexandria City, Fairfax County, and Arlington County in Northern Virginia. Happy to be here.
I'm Emmett Hanger from Augusta County, and I represent Augusta, Stanton, Waynesboro, a good part of Rockingham County, and on the east side of the mountain, Greene, Madison, and Culpeper.
Good afternoon. I'm Janet Howell. I live in Reston, and I represent parts of Fairfax and Arlington counties. Nice to be here with you.
And she is the chairperson. And Cliff?
Good afternoon. I'm Cliff Hayes. I represent the 77th House District, which includes majority parts of Chesapeake and a small portion of Virginia Beach. Happy to be here.
So for your information, our new software upgrade that has call-in technology is having some issues now. And so we do have a few members on listening online, and if they have a question, they will be texting me or one of the staff with questions they might have, and that is Delegate Brewer, Delegate Jones, and Delegate Bell are listening in. And this oversight hearing would not be happening today without our stellar staff. For the House staff, Susan Massart, and with the Senate staff, Mike Tweedy. And I'm going to ask them to introduce our management fellows that are joining us today on the podium.
Thank you, Mr. Chairman. So on the Senate Finance and Appropriations staff, we have Payne Tarkington, who's a Virginia Management Fellow, will be with us. Actually, both of them will be with us through the end of the session. So straight to my right.
You mean the one in January, that session?
Yeah.
Okay.
Through the 2022 regular session. And we have, we're delighted to have Amy Cochran on our staff, and she'll be here following a number of issues.
Well, terrific. Well, it's time to jump right in unless a member has an opening statement of any kind to make. Okay. I know you've been looking forward to this, Senator Hanger.
Yeah,
especially.
To say, but I'll reserve it.
Okay. Gentleman reserves his time. Our first speaker today is Cheryl Roberts, who's the Deputy Director of Programs and Operations at DMAS, Department of Medical Assistance Services. Welcome, Ms. Roberts.
Hi, welcome. Thank you for having us. And Karen sends her regards. Okay, what I'm going to do...
We're all thinking about her, by the way.
Can you hear me? Yeah. Better? Okay,
yep.
Good. What we're going to do, Tammy and I are going to basically give you an overview of what we're doing for managed care and oversight. We're going to do it in a couple of places. See if it will work for us. It is not. Thank you, Mike. And can you help me make this work? Gracias.
Oh, if it's working, actually.
I can talk loud enough. Can you hear me if I talk this way? Can you hear me better?
Yes.
Okay. What we're going to do is I'm going to give you a brief overview of managed care, and I'm going to talk about contract monitoring and oversight. Then Tammy is going to talk to you about network adequacy, in particular the community mental health providers, and we'll talk a little bit about Project Cardinal and what we're doing for transparency. So we will go through the deck a little bit. First thing is for for your group, I wanted to talk about what DMAS represents. When we talk about DMAS, we cover 1.7 million of Virginians. Our mission statement is to improve the health and well-being of Virginians through access to high-quality health care and coverage. And when people ask, what does Medicaid serve? First, people have to remember it's children. We serve children. That is what we see nationally. Pregnant women, we do about 25 to 30,000 deliveries a year. We do 1/3 of the deliveries in the Commonwealth. Older adults, disabilities, and then with the Medicaid expansion, our adult population increased to about 700,000. When you think about Medicaid, you also have to ask what kind of delivery system that you want to have. And in our case, we picked managed care. We are not the only state. There are 40 states that have managed care. About 60 million United States citizens have managed care now for Medicaid. When we look at it, we are part of the trend. Why did we do it? We do it because, one, the biggest thing is the service that we provide for the members. Managed care provides us services that we have not been able to replicate, as well as give budget predictability. But when I ask people what's the rationale, the biggest thing is that we want to move from just paying for a unit of care, just paying for a service, but actually move the whole system so that we are rewarding value and rewarding care. So let me just give you a brief history. Why do we do managed care? The biggest thing is for the member. And I have a lot of discussions about that. When I first got here to Virginia, we had a Medicaid in our fee-for-service business, and it was very difficult to find providers. In fact, I remember driving into Tidewater into an abandoned school building, and that's where our children were going to get care. I went to Charlottesville, and we were in an empty grocery store, and that's where our kids got care. And Janet remembers when we had those type of discussions. And so we actually went to the managed care companies to actually get networks. That was what we were looking for, so that when a child went into a pediatrician's office, they were not stigmatized, that the card would allow them to get services. And so that was actually the beginning of it. But now what we're looking at the holistic part of the member. We're making sure that the member has services and care coordination. I'll bring that up a little bit. But what the plans bring to us, in addition to networks, is that most people focus on clinical services, but clinical services is about 25% of your health care. 30% of it is actually healthy behaviors. In fact, Doug was talking about that. And some of the things that plans bring that we don't give them credit for is smoking cessation, which, by the way, thank you for giving us smoking cessation in July, wellness, those kinds of things that will actually help, including food, helping with housing, and making those type of connections. So most of the time when you hear us talk about managed care, you hear us talk about care coordination. And care coordination starts from the beginning. It starts when the person actually gets enrolled in the plan. We actually do health risk assessments that decides on what kind of needs the person needs. Yes, in CCC Plus, one person is being assigned to actually help the person navigate through the system and actually get personal care and the things that they need. But even on the medallion side, there's care coordination that's being placed. Because, again, it may be navigating through the system, or it may be needing additional services that are not traditionally in the Medicaid package. And so one of the things we're always happy to see is how care coordination works, and then how we watch our members actually thrive under this new model. We have two models right now. One is Medallion 4, and the other one is Coordinated Care Plus. For Medallion 4, the easiest way to remember it is a commercial product. If you think of it like a commercial product, that's the best way to think of it, with the addition of substance abuse, transportation. We actually transport people to the service, as well as community mental health services. That's what Medallion looks like. If you're looking at CCC Plus, which we're very, very proud of. By the way, we're one of 23 states that actually have this kind of program, and we were one of the first and considered one of the best. It's actually talking about more complex children, complex adults, people who need additional services, personal care, people who are duals. That group is in that program, and Tammy will later talk about how we're trying to bring the contracts together for those. And then we contracted through procurements for health plans. Right now we have 6 health plans 4 of them are national plans. The 4 national plans are big ones. They are actually in 10 states or more. And then the other 2 are big regional plans that are owned by our health systems here. And so together, they are able to take care of about 1.8 million of our members. The question was asked, what do we do for monitoring and oversight? One of the things that I'm known for is that, you know, how some people have hobbies. I'm a managed care junkie. I actually spend a lot of energy watching what managed care looks like nationally. So, because I always want us to stay on the edge of it, right, to be in the head. So the first thing is to realize that once we entered the managed care business in a big way, we changed our scope. So we used to be considered just as a payer. Now, because of managed care, we are also focused more on policy, and the big one is contract management and oversight. So now we have teams of people who actually focus on contract monitoring and oversight, because it's not like we gave the keys to the car to the managed care organizations. We have to make sure that everything is in order. So first thing is that we have to improve. The person that we have to say yes to is the feds. CMS actually has a whole list of things that they want us to do for monitoring and oversight. In fact, on June 28th, this month, they just put out what they wanted from all states for monitoring for MCOs. And what we're happy about is, I'm going to go through this quickly, is that not only are we doing it, it turns out our annual report is the prototype that they use. And so our annual report, in case you want it, is online, and we send it to CMS. And what I'm pleased with is that when you see the guidance, you'll see that we match. They used us as the prototype. So I think this sometimes. So they asked about program enrollment, financial performance, encounter data. We created our own encounter data system that trains claims to data, grievances and appeals, obviously networks, quality, I'm going to talk about a little bit, corrective action, program integrity. And in order to stay that way, Tammy and I work with all the national groups. We work with NADNIT, with the Medicaid directors. We work, both of us are chair of TAGs. TAGs are national groups. I'm the managed care one. She works on the long-term care one. And so we make sure that not only are we doing what we can for Virginia, that we also work with our national partners. So 3 things I want to bring up over here. One is contract monitoring, which I'm going to bring up what we do there. Value-based purchasing, we'll talk a little bit more there, and transparency and engagement. Tammy's going to talk about network monitoring, because you can read, so I'm not going to have you go through every bullet. Let's talk about monitoring. This is where it hits the road, right? What do you actually do? Well, first thing we do is that we focus on our contract. That is probably the key to everything. We do annual contracts and rates. Now, how do you create a contract and a rate every year? First thing we ask is there any changes have to do federally? Number 2 is you, okay? Governor and you. Anything you ask for, we put in the contract to make sure it's going to get done. If that's something you want, we make sure it's there. Any changes in policies, and then reports. We have hundreds of reports. Both programs do, in order to make sure that we have checks and balances in. We've created compliance teams. We have groups of teams of people whose job it is all day long to look at the services that are being provided, the care that's being provided, the access that's being provided. They look at the reports, they trend the reports, they actually make those type of decisions. They look at the issues. If the issue is a one-time issue, you just deal with the one-time issue. If the issue is an issue that's prevailing, where you see a trend, we decide if it's a plan issue or it's a program issue. If it's a plan issue, that's being addressed either through a cap, that means they get some corrective action, or at that point they get a sanction. If it's an issue with the whole program, we stop everything we're doing, we make a whole subgroup, we try to address the issue, okay? Because the idea is not to make it prevailing. Same thing with complaints. When we get a complaint, we address it right away. I think you all know that. You contact Karen or any of us, we answer that complaint on a dime. If it's a prevailing issue, we stop to make sure we correct it. We hire contractors. We have hired contractors to actually evaluate and to monitor the health plans too. We don't do it all on our own. If we have a question, we make sure that we have that kind of scrutiny. Tammy's going to talk about how we're hiring for example, an auditing firm to look at determinations. We don't try to do everything on our own. We make sure that we get the kind of experts. For example, we use a contractor to look at the plan's administrative work to make sure that they're not doing anything in the administrative burden. So we work on that. We meet with the plans every solitary week. They love us. We're their best friends. We have quality meetings with them, and then we also have subgroup meetings, so to work on a topic. For example, when we work on telehealth, we'll do that. COVID vaccines, we'll work with them, because the goal of the exercise listing COVID vaccines was to make sure that our members got that information and they were getting vaccinated. That's a good example of working as a subgroup. And then last but not least, we also welcome your audits from the JLARC and the Joint Commission that also come to visit us, and we welcome them when they come. Okay, quality. We were, depending on who you talk to, number 1 or number 2 to actually do quality with managed care. Some people say I have a ongoing fight with Tennessee. They said because I didn't make it mandatory in the contract, we were number 2, but we were number 1 to ask for NCQA. Why? Okay, some of it has to do with background. Most of the people who work on managed care actually came out of a managed care background, and NCQA is the standard. So not only do we ask that each plan have NCQA, we reward them for the standards that they have in terms of HEDIS and in terms of whether or not they get the equivalent of exceeds versus just meeting. HEDIS means a lot to us. So we do rewards on that. One of the things we did, we were the first to actually do stars so that the member can actually choose a plan based on the stars, based on the HEDIS scores. And then we also have, as you see here, performance incentives where we do withhold programs. Basically saying is we want to see an increase, for example, in well child visits. We want to see many of our members to get AC1 screenings. Those things are rewarded. And so that's part of the process that we do as part of our quality. But we also have population and quality goals and also population and quality reports. For example, foster care. We actually have a whole series of reports that are foster care kids because those children are special. We have to make sure that they're being transitioned well, but also that they get well visits. We work with DSS to make sure they get their well visits and dental care because those things are critical in terms of the health of the child. And then, last but not least, is the money, of course, right? You can't leave without talking about how do we do money. One is that we use Mercer as an actuarial firm, and Mercer helps us with actually the development of rates. But here I want to stop because I can talk about BOI. That's what we like to have all of our plans do, and we look at all the money. But one of the things that changed in the last 3 years that I think has been valuable is the External Financial Review Council meeting that we meet quarterly. That meeting was a game changer for us in a positive way. Now, because of that meeting and that transparency, I will say that for the whole agency, we look at every dollar and every penny much more in terms of our scrutiny. So that monthly, we actually look at every trend. We look at what was expended by each plan, what are the trends, and we can look at the changes. So, for example, in my case, because actually I do, as you see, the medallion population, I saw well visits went down. I see that on a monthly basis. I can see that it's actually discussed. So that our goal is that by the time we do the EFERC on that quarterly basis, we have been educated, we have answers, we actually work on that. So there's no surprise. We don't wait till the end of the year and say, surprise, surprise, this is the money. We actually now are very, very, very focused on looking at trends and money. And then there's a CFO meeting. We have a meeting quarterly with all the CFOs so that we can actually understand the things and their challenges they're having financially. Why? It's because we figured out that in order to do the oversight, you have to look at all the different pieces in order to make sure that you're ensuring that the money that we're spending is being used properly. All right. Any questions on my side?
Anybody have any questions for Ms. Roberts?
Mr. Chairman?
Yeah, Senator Edmund.
I'm newer to this commission. I'm not as familiar with the performance incentive award programs or quality withhold programs. Could you just briefly give me a overview?
Mm-hmm. It would be equivalent of what I would do is, if you were you, I would take let's say 2% of your salary and say that you'd have to earn it back. And so basically, we would set goals and say that you can either earn it back. So in this case, for example, I'm using on one side of the program, you would say we'd hold the money and we say if you do not get so many well visits, so many prenatal care, so many things, then you don't get that money. But the person who does could actually get rewarded for it. So that's part of the process.
Let me ask you a question about, prior to managed care, DMAS had many, many employees that oversaw the fee-for-service program. What do all those people do now?
The world changed, obviously. So some of those people went into managed care business, either indirect or directly. For example is...
Went into the private sector?
No, for us.
Okay.
Okay. An example is, we used to have a transportation team that just did fee-for-service, right? So now that team also does the managed care oversight. So that whole team now, because obviously the fee-for-service shrunk, they do the transportation for the whole. They oversee all the plans. So for example is, Bill sent out an email about the hurricane coming to not just the fee-for-service providers, but all the providers in the managed care system. So what we're doing is making transitions. So some of the people who did fee-for-service now, for example, are working on behavioral health. Some of them are working on, because of what we did for CCC Plus, there's a unit that does personal care. And again, personal care across the board. So we have repurposed people in terms of their subject matter expertise, because we want them to look at it in a different way.
Okay, very good. Are there any further questions at this time? Okay, thank you so much.
You're welcome.
That was very informative. Welcome, Tammy Whitlock.
Oh, sorry, that one, okay.
Good afternoon, Ms. Whitlock.
Thank you all
Good
for
to see you
having us
again.
today. I'm Tammy Whitlock, and I'm one of the deputies at DMAS, and I oversee the complex care areas. I've talked to some of you recently, as a matter of fact. And my responsibility today is to talk to you about network adequacy, and we're going to go ahead and just talk about the specifics that you guys have heard about TDT, therapeutic day treatment, because that's been a topic that I've heard when we've had conversations. It's been the top of the list. So I think we should just go ahead and let's talk about some data, where we sit right now, and what we're planning to do coming up. So MCO network management. The MCOs have a responsibility to ensure that their networks are sufficient to meet all of the services and allow any member to get any service that they need across the state if they are statewide. There are four components that we believe are involved in the network management. The top component, network relations and contracting. They have dedicated provider staff that assist providers with credentialing, with contracting, with they have a call center. Each plan has a call center, and they can answer questions about claims. So it's a relations piece. And many of the plans, if not all of them, have regional staff. So it's not just one central location. They're actually out in the location where the providers are, and they can meet the providers where they are, which is very helpful because each region, as we all know, across Virginia is very different. The second part is the network capacity and compliance. The MCOs have the ability to leverage their commercial networks. You heard Cheryl talking earlier about national plans. Well, they're also, all of the plans have commercial products. So they can say to a provider, hey, we've got this all-payer contract, and if you want to participate with us, you're going to need to serve our Medicaid members too. So that helps to bring in some more providers for our Medicaid members, because we did in fee-for-service have difficulty in some areas recruiting providers to be Medicaid providers for us. And so that's a plus that the MCOs have. The one thing that, and this is one of the linchpins of what we have to talk about through this committee, I think, is the MCOs do not have to take any willing provider. That is the any willing provider, air quotes, is a common term that was used, that has been used for fee-for-service. So if you think about fee-for-service, if I'm a provider in fee-for-service for whatever service I choose. I go to whatever licensing board I need to go to. I get licensed for that service. In fee-for-service, you sign up with Medicaid and you're a provider. That's it. So for managed care, the difference is the managed care organizations are at risk. And by being at risk, they have the ability and they should have the ability to pick their providers who they want in their networks. And that is common. I'm sure you guys have had to call ahead and say, oh, are you in Anthem's network? Are you in, whoever you have for your health insurance? It is a common practice that MCOs get to choose who's in their network. Any willing provider, it's a difficult concept that I think has been difficult for a lot of the providers we have who are Medicaid only. And if you think about community mental health providers, personal care providers, a lot of our waiver providers, they only get paid by Medicaid. They don't get paid commercially. That's not a service that's covered outside of Medicaid. So it's a really important factor that has been a very difficult transition for a lot of providers. But that is one piece that we just need to keep in mind because the MCOs are at risk. It is a provision. It's actually a federal allowance that they can choose their networks. MCOs can also pay out of network. Okay, so if an MCO has a member who has a specific service need and they can't find a provider who can do the services or maybe not do them fast enough that the person needs, they can actually contract with an out-of-network provider, somebody who hasn't signed up with them, but they can contract with that provider and say, we want you to do this service for this member for this time frame. Fee-for-service was not like that. If you wanted to provide a service to a member, you have to sign up to be a Medicaid provider. And many times that was a difficult thing to convince providers to do on a large scale. Member options. Members also, through MCOs, they have ability to get help if they are having difficulty finding a provider. If you're having trouble finding a cardiologist in Newport News or somewhere, they can pick up the phone and call their member helpline, which fee-for-service didn't have a member helpline. They can call the member helpline and say, I just can't find a provider in Newport News who can see me anytime soon. Can you help me? And then they can help that person find a provider. The other thing about on the member options I want to point out is that members have choice. So remember, in Medicaid, members always have choice of providers. The difference is with managed care that their choice of providers is limited to who's contracted with their health plan. So instead of saying in fee-for-service, you have a choice of the plethora of any provider who's enrolled with us, it's if you are enrolled with a specific health plan, then your choice is limited to whoever is contracted with that health plan. And then innovation, Cheryl mentioned that MCOs have the ability to do different contracts, to do value-based purchasing, different things that in fee-for-service, it's exactly what it means. It's a fee for a service, and that's all you get. There's no flexibility there. So network adequacy. Cheryl's been talking about how we monitor plans and what we do from a DMAS perspective. And so you'll see that DMAS conducts network reviews to make sure that all the MCOs have adequate networks. For example, when we brought up CCC+, we had to ensure that each MCO had network adequacy for every service. And what that means is there's a time and distance standard that they have to meet. But you have to map all that out, and you have to make sure that if Susie lives in this part of the state and she needs a pediatrician, there needs to be a couple of pediatricians close enough to meet the time and distance standards for her to get there. If not, then the MCOs, they wouldn't meet in that area. And we did have that happen early on with CCC+. It's not the case anymore, but we did have that happen early on. On the right side of this screen, just to point out, there are federal rules around network adequacy. So you'll see that there are federal rules around staffing, around The MCOs have to ensure that there's an adequate number and mix of providers, that the hours of operation, for example, for Medicaid members aren't different from commercial members. You know, sometimes that happened where they would say, we're only going to see Medicaid members from 4 to 6 or 8 to 9, and they cannot do that. So that's a federal provision. The MCOs have to make sure that the providers make accommodations for physical disabilities, translation services. I talked about the time and distance standard. And then the last one, the flexibility for MCOs to operate with selective networks. That is a federal allowance that is available to the MCOs. Okay, so this slide points out when there is a provider agreement change, so a termination. What happens? What does that look like for the member, and how does DMAS get notified? So if you look at the first block, the member must be notified if, for example, the MCO says we don't need this provider, they're no longer going to be in our network. They have to send a letter to the member 30 days ahead of time before that termination date and give them notice to say, hey, this provider is no longer available for you, so we'll help you make a transition to another provider. If the provider makes that termination, then the MCO has to get that letter out the door within 15 days of being notified. In the next block, you'll see there are several provisions, timing provisions, of how quickly the MCO has to notify DMAS if there's a change in their networks. So if the MCOs, if there's something going on with, let's say, fraud and abuse, that's an ASAP. That's within 48 hours. They need to let us know. If it's a change where the member's access could be reduced, they have 30 days to notify us. So it varies. It kind of goes from immediately, if there's a serious quality of care issue, to 30 days. The last block is the one that's important. And this is the block, the issue that talks about how the transition is done. So normally, the MCOs help the member transition within 30 days. They send them the letter. They put something on the letter. If you need help transitioning or picking a provider, please call your care coordinator or call this number. If it was when the termination started for community mental health providers, which you're going to see some data in a minute, in the fall of 2019 or earlier in 2019, DMAS worked with the MCOs and we went a step further and we said, okay, if you terminate for whatever reason a community mental health provider, you're going to notify us as you normally do, but we also, in addition to knowing that you've terminated them, we need to know who the member is, when the services were terminated, and where they're going, who their new provider is. And we did this to make sure there was no gap in service at all for that member. And that happened on every single termination. The other thing I'll point out is that if a member did not want to change their provider and their provider was with another MCO, we allowed that member to make that change and switch MCOs. They were able to do that. Okay, so the puzzle slide. We put the slide together because we were trying to kind of point out what was our reasoning. Cheryl talked a little bit about the money side and some other things that happened, the reason we went to managed care. But we started thinking about it, and the real reason is that we had a bifurcated system. We had a system where we had, if you guys remember, the BHSA, remember us talking about that back in 2013, Magellan? So Magellan came in 2013, kind of our toe in the water for managed care. They weren't managed care, they weren't at risk, but they did do some things that were similar to managed care. They did some screenings, they did a little bit of credentialing, and they did some quality improvement projects with the providers. They knew what was going on for the fee-for-service side and the community mental health services that were carved out of the MCOs, and the MCOs over here had the rest of the services. So real-time care coordination couldn't occur. So what needed to happen is that we needed to bridge that gap right there. So we needed to, the reason the MCOs, this is a better system, we believe, is that the community mental health services are now in with outpatient services, inpatient services, pharmacy services. So the MCO now can look and say, wait a minute, this person just had an inpatient stay. You know, they've changed their medication. We may need to do some intervention here. We couldn't do that before. They didn't have the whole picture. So this was a really important move, we thought, that we made to make a holistic model of care. So real quickly, TDT, therapeutic day treatment. I've talked to many of you and some of you in the audience about this topic, and I just wanted to show you a little bit of data. We went from 2015, we had about 16,000 kids in TDT. Up to 2019, we had 19,400 kids. As you can imagine, our 2020 data is a little skewed, but we are working on that, and we will have some more updated data, at least for the first part of 2020. It's important to note that the information, the 19.4 is about 3% of the kid population in Medicaid. And if you, let's see, go to the next one. So the next slide is what probably people are interested in. This is information on the terminations that occurred in the fall of 2019. So this slide shows the percentage of the providers that were terminated in each region. And most of the providers that were terminated were largely inactive, where of those removed, it was 10% of those had not really billed for any community mental health services since January of 18. So following the terminations, you can see that at least 89% of the TDT providers remain in the region. So that light blue shows you the percentage of the providers that were terminated in the region. The dark blue are the ones that are left. And of course, with the report that I'm going to talk about in a minute, this will be updated as we go forward. And I thought this was a good visual, just to let you guys know, different parts of the state, since you're all from different parts of the state, you can see this is the number of TDT providers in each region of the state as of fall of 2019. So refer to the report. We were directed to put together a report on the terminations. And just as a reminder, these are the 4 areas that we will be concentrating on: the number of providers in the network, in which geographic locations, the total number of terminations, the localities they were in, and the number of Medicaid members they were serving at the time of termination. As Cheryl alluded to earlier, Myers and Stauffer will be doing this report for us, so they will be gathering the data from the MCOs and conducting the report. So real quickly, we talked about, we were directed to combine the programs, as Cheryl talked about earlier, and our work has started on that. We've started to streamline and align the managed care contracts and the MCO administrative task, and this will help streamline and make things more efficient. We are rebranding the program. We want the program to be rebranded and be called Cardinal Care as a whole. Other states do this. You may have heard Hoosier Care, 10 Care. There's all these other acronyms and other names for Badger Care and things like that out in other states. And so we really want there to be less stigma for the Medicaid program and to call it Cardinal Care. This will strategically align the care management and the models of care. Right now we have models of care specifically in CCC+. So the MCOs have to look at different populations, and they have care coordinators, and they have different requirements for each population as to what they have to do. So we're going to streamline that across all populations with this move. The rates will be set based on population characteristics as opposed to the program. The medical loss ratios and the underwriting gain provisions will be combined. And then for open enrollment, it'll be, the whole program will go through open enrollment. It won't be two separate open enrollment processes. You know, this will be a little bit better for the members. We hoped that if a member had to switch from Medallion to CCC Plus, or in some cases vice versa, we hoped that was invisible, but it wasn't invisible to the provider. So the provider had to then switch numbers of who to bill and how that was going to work, and it was sometimes confusing. So this is going to be a good move for providers as well. We anticipate this taking place, the contracts being combined by 7/1/22. We have put together a high-level plan for this. We have contracted with a national expert to help us with this. They will be able to bring in best practices from other states where they've done this. They can look at other levers that we can use for transparency and for compliance monitoring. It's just going to be a better system, a more efficient system, and following the direction of the General Assembly. One last slide. We want to brag a little bit and let you know what's out there. We did redo our website. Heard for many years it's been a little difficult to find things on our website, so there are a lot of new web pages out there. Quality and population health, there's a page for that out there. Value-based purchasing, behavioral health is out there, and then we are also working on reorganizing where our studies and reports are. We always heard it, where is that report? I can't find that report on your website. So we will have a place where it's more transparent, where providers, you guys, anybody in the public can just go right to that spot and find the report you're looking for. The public dashboards are exciting. We will have a public dashboard on behavioral health and what we just talked about. We will have a public dashboard on service authorization and appeals and grievances, on the health plan networks. And right now, you can go out there and look at the MCO expenditures dashboard, the financial performance dashboard, and the enrollment and health plan membership dashboard. That's all active right now. So the rest of this are appendices, so I'm not going to go over those, but there's just more information in there. If you get bored one night and you want to go through that, help you go to sleep, you can find some things in there to read, but it should be more informative to help you if there are any other questions. I'm happy to answer any questions.
Just 1 second, we did have a new entrant to the podium or the dais
we
today,
did.
and that is the esteemed Senator Barker from Fairfax County. Do you want to introduce yourself? And the vice chair of this
Sure.
Oversight Subcommittee.
Yes. Yes, I'm Senator Barker, represent parts of Northern Virginia in Prince William, Fairfax, and Alexandria, and did have a little trouble with a couple of vehicle fires on the way down, so, but it finally did make it, so thank you very much. So
Very good. He's also lucky and
I was afraid that my vehicles are going to become the number three that going around where we were, so
yeah,
did make it.
he and Senator Evan both have the benefit of representing some of the same people in the 43rd district that I represent. So I have a couple questions, but first I'll ask the folks on the podium. Delegate Hayes.
Thank you, Mr. Chairman, and thank you, Ms. Whitlock, for your presentation. We really appreciate it. I noticed as the final slides, as you closed out your presentation, you pointed to website design as well as some of the public dashboards. And so that kind of points to a lot of the public-facing pieces.
Mm-hmm.
But my question is more internal amongst agencies. And I'm sure that there are communications data that you need and that other agencies need. And I'm just wondering how that flows with the interfaces of systems and the difficulty or ease that you have in getting the necessary data that you need.
Yes, thank you, Delegate Hayes. That has long been an issue. I think that we, in many ways, have worked, especially within our secretariat, to try to find ways to work around that. But it's often been talked about that we need to have one central location for data. I don't know. need to say anything. But we would, I think it would be beneficial for us to have one, but it's very difficult. I mean, everybody has different rules. You know, DOE has FERPA rules, we have HIPAA. I mean, it's just, we have explored that. I can remember when Secretary Hazel was here, and there was a big push for that, but open to having discussions about that. Absolutely.
Be happy to follow up in that regard.
Yeah.
Thank you, Mr. Chair.
Thank you, Mr. Chairman.
Senator Hanger.
Couple questions. When someone is disenrolled as a provider, is there a formal appeal process?
There is, if there is a, can you guys help me? There's a formal appeal process, right? That everybody gets. Yes. They get a letter, and there's a formal appeal process that they can follow. Correct.
Okay.
To the MCO. To the MCO, not to DMAS.
Right.
But to the MCO.
Okay.
Depending on, okay, that's why I was looking at you guys, not for the no cause. Yeah, so there are a couple of different, and that's one of the issues, Senator Hanger. That's one of the issues is that the MCOs do have the ability to dismiss providers for no cause. So which means they just don't need that provider in their network, or there are other reasons. There's not a specific reason, and I know United and Anthem are talking later, they can speak to that, but there's not a specific reason that they would give that would be appealed. It's just that they no longer need that provider in their network. So if they dismiss for no cause, there are no appeal rights. If they dismiss for cause, so if there's a quality of care issue, if there is a fraud issue or something like that, there are appeal rights.
Okay, Mr. Chairman, that seems a little bit convoluted there if you dismiss for no cause and there's no appeal. Is it?
Yeah, I mean, it's allowed, is it federal, Jenny?
It's allowed in their contracts.
Yeah, it's part of their contract that they sign, and Mindy can probably speak to that better than me, but that is part of the contract that they sign, that they can be dismissed for no cause, and there are no appeal rights. That's in the contract.
But,
Commercial as well as Medicaid.
but Mr. Chairman,
Yep,
follow
Senator
up,
Hanger.
but there should be a reason though, I suppose.
Doesn't
No
have to
cause,
be.
but a reason.
Could a reason be we already have enough providers already?
Right. So there would have to be a reason if there was no cause.
You guys agree with that? Yeah, can you step up? Do you mind if they help
No,
answer
that'd
that
be great.
question?
That'd be
Please,
I don't want to say something inaccurate.
please introduce yourself. We want to get to the bottom of this.
Hi, everybody. I'm Dr. Cleo Booker. I am with United Healthcare. I am the Chief Clinical Operations Officer with United Healthcare. I oversee all of the national behavioral health plans across the U.S. And so in regards to your question about no calls and is there appeal rights, appeal rights are offered if a individual is deciding to remove themselves. They can also ask to rejoin. If we decide to remove a provider, there are appeal rights depending on the reason. So like Tammy was saying, if an individual or a provider is under investigation for fraud, or there's an indication that there's a quality concern, or there's probably suspicion of abuse or anything like that, we can say we no longer want you in the network because we suspect something. But the provider does have the opportunity to appeal. The no cause, or removing a provider from a contract without cause, that is because we are evaluating our network. So we're going through those network adequacy standards. Once we get to a point where we say, all right, we are sure that our members can be served in a county, in a region, in a state with the providers in that network, we have the ability to start looking to say, this provider doesn't necessarily offer a continuum of services, for example, and if we remove them from the network, we still meet network adequacy. And so in those cases, that is a without cause, and there is no appeal rights. However, the provider does have the opportunity at any point to ask to rejoin. So if that provider says, actually, I do have more to offer you, United, I now am offering therapeutic day treatment as well as family therapy, group therapy. I now have a continuum of services that I want to offer you. can I come back into your network? There is a process for them to actually rejoin.
Okay. You said, I have a two-part question. One is there any demographic data on the providers that have been terminated? For instance, is there any racial, ethnic class that, do you have data on that?
Good afternoon. My name is Taylor Rhodes. I'm Director of Provider Experience for Anthem. I can address that. For Anthem, we do not. Most of these providers are contracted with us at a group level. We do not have demographic data in terms of race, ethnicity available to us.
And the department doesn't keep that either? Okay, so you mentioned earlier that if a provider, if you tell a member that a provider is no longer available to them, could you explain the process again, that you could go to another MCO? How would they know that?
Well, they would, number one, they would get that letter, but they could also follow up, make that phone call and say, hey, I don't really want to stay with you. I want to stay with this provider. They would then call Maximus, who is our enrollment broker, and Maximus would say, okay, well, looks like your provider is in XYZ plan. Do you want to switch, or these two plans, which one would you like to switch to? And they could just make the choice of which plan they would like to switch to. And that did happen.
Okay.
That did happen.
Okay. So we're a little bit behind schedule, so I hope you'll all stay around so I can ask about the implementation of the dental benefit, the merits or non-merits of having some of the MCOs specialize in some really specialized care for some fragile populations, and where we are with value-based purchasing on the skilled nursing situation. That's in the budget too. Those things that we want to learn about later, but we don't have any time to do right now.
All right. Thank you very much.
Okay, thank you. That was great. So our next speaker with us today is Jenny Reynolds from Anthem Health Keepers. Welcome back to the committee, Ms. Reynolds.
Good afternoon, and thank you for having us. Appreciate this opportunity.
But before you speak, we have an important member of our subcommittee. It's just arrived, and that is Delegate Betsy Carr from the FAN and from the south of the river, too. Beautiful district here in Richmond. Would you like to introduce yourself?
Thank you very much. Thank you, Mr. Chairman. It's a pleasure to be here. I apologize for being late. It was an event at Northern Neck.
Okay, that's not a good excuse. All right. We'll live with it. Okay, Ms. Reynolds.
All right, thank you. So what I want to do is kind of walk you through from the MCO's experience, the CMHRS carve-in, and kind of how we progressed through the years, made the decisions we made, and where we're at today. And really, at the end of all this, show you some member outcomes and really be able to demonstrate what we were able to accomplish with the result of our work that we put into this program where we're so committed to. So just a reminder, and Tammy and Cheryl had talked about this a little bit, but when we started and when the CMHRS services were carved in, you can see in this chart the three main services, mental health skill building, TDT, and I always get this one. Intensive, I could get intensive in-home services had increased. You can see the skill building services almost 1,000% over an 11-year period, 500% for TDT, and another 130% for intensive in-home. I don't know why I can't say that. The expenditures, they were just out of control, and there was not a great deal of oversight. So in January of 2018, we wrapped up the carve-in. So we had started in, I want to say, August of 17 when Medallion 4 went live, and we regionally rolled in with Medallion. And then in January of 18, when CCC Plus was implemented, the remaining services were carved in across both programs. And I will say, as we went through the rate-setting process with these new contracts, there was an expectation of 13% managed care savings expected in these behavioral health services, and that was part of that rate buildup. There was an absolute recognition that there were savings to be found, that this was not an efficiently run program. So we went into this, and this is what we did in preparation. So there was an agreement with DMAS that we would not terminate any of the providers at the onset of the program. There was a lot of concern. We said, let's bring this on, start the process of the service authorization process, really introduce the providers to managed care. And so for the first year, we went through this process. As we were bringing on these services, we held multiple webinars. We attended association meetings. We did one-on-one meetings with providers. I can't emphasize enough the outreach we did with these new providers as they were coming into the managed care system to really get them prepared for the expectations on their documentation, following our authorization rules, and just understanding that there was a different level of oversight. So what did we see over the course of that year? Here are some behaviors, or some less appealing behaviors that we found through this course. And this was not across the whole program, but I want to make it clear, we found providers that always requested the maximum number of units for every member in their practice. Every single member they thought needed the highest number of units of services that they could get with no delineation. We also had members that in a practice had the exact same care plan for every single member in that same practice. There was no individualization. We found situations where when we outreach to the member's guardian with children, they didn't even know that their children were getting TDT services through their school system. So they weren't even aware that their children had been given a behavioral health diagnosis. We also found situations where there was, frankly, false information on some of our authorization requests. And so through this process, and I know we're talking about cause and no cause, there's a big differential between cause, where there is potential harm to our members. When we say quality of care, there's member danger involved. With the false claims or with the bad information, we sent those members to our SIU and certainly did all of our fraud and abuse activity like we would. But then when we find behaviors where the member's not at risk, but it's not good behavior, and it's not really the best outcome for the members, that was where, frankly, we were evaluating all of these behaviors with this network. And when it was time to say, when DMAS gave us the green light that we could, reduce our networks to what we would do as a managed care organization, we took all of this into account. And we were contractually able to term with no cause. It was a mutually standard language that, frankly, we have in all of our agreements with all of our providers. This was not a unique method of termination. What we had to do, though, before we did all that was, Tammy discussed the DMAS oversight, but it was, I think, in my memory, even a little more stringent than what Tammy described. We actually, in the case of the CMHRS network, we didn't notify DMAS when we termed. We had to notify them who we were going to term before we termed. And so they knew exactly who was on our radar. We had to give them a list, not of just how many members were impacted, but we had to give them a list of the members that were impacted. And we had to show them evidence of the alternative providers and that there was more than adequate coverage for our members to seek alternative providers to cover their care. And of course, we worked with our members to find those, to enroll with those members. The terminations were clustered in regions or areas where we had a very dense network. So we did have too much of a network. And I think that's an important point that I didn't say when I introduced all this. It's completely uncommon for us to start with an already established network. When we bring on a contract or we take on new benefits, we build our network. We were given this network. We didn't choose it. And so this was our opportunity to create the network that we really felt was most efficient, most effective, adequate, in that there was enough providers to give our members the best outcomes they deserved. And I think that is really the crux of all this, guys. When you see details like every member needed the exact same number of units of service, that doesn't feel like members are being treated as individuals. It feels like members are being treated like a line on a spreadsheet to make a revenue number. That's not what we're in the business of doing. So let's talk about what happened after we went through these terminations. So here's some data. I want to talk pre and post carve out. So this is where we went when the CMHRS services were in fee-for-service into 2018. So these top two graphs, we had not done anything to our member network, but we did, apply our standard procedures and our authorization rules. So we saw almost a 20% decrease in ER visits per 1,000, and we saw over a 12% reduction in our inpatient admissions per 1,000. This is just literally bringing these services into managed care and getting that clinical involvement. This is where care coordination comes in. This is where people start working with the members on an individual basis and find out what they really need so that they're not using the ER as a PCP. So maybe they're going to that community service board so that they're getting the right service in the right setting. Then in 2019, after we did our network, our first round of network terminations, you can see we'd already come down almost 20%. Our ER visits stayed about flat. It went up less than 1%. And our inpatient admissions continued to go down. So this is in addition to what we'd already reduced in 17, they came down almost another 5.5%. So, this is just one representation of, you'll see, with ER and inpatient, these are big indicators, of the general health of the membership. And often what we see, behavioral health services tend to go up and effective behavioral health services go up and these kind of services come down. And so this is just, and I want to share, this data is outdated because of COVID. We don't want to put the 2020 data in here and, proclaim all this utilization dropped. That wasn't driven by any of the actions we took. It was driven by the pandemic. So we're going to be addressing COVID and how we share that story. We're working on that now with our actuaries. And then let's talk about our TDT services. And this is one I'm really proud of. After we changed and we did our round of CMHRS provider terminations, for members that continued to receive TDT services, so not all of the members receiving the services kept receiving the service. They didn't need those services. So these are, I want to say these statistics are only for the members that had impacted providers. Those members, after the terminations, their behavioral health admissions went down 15% and their ER visits went down 18%. But what I'm even more proud of, their behavioral health therapy utilization went up 35%. And that was a big thing, and I didn't highlight it when I was sharing some of the observations we made over that year, but we were often finding members were getting services like TDT that clinically require outpatient therapy, and they weren't receiving any therapy. And so seeing these therapy numbers go up was showing the effect of getting the right providers providing our care for the members. And then for those members that didn't get TDT services at all after the terminations, because it was found they didn't need those services, and I'll say they may either have needed services at a higher level or they didn't need the services at all. It's all individualized, which is the key here. They had a 35% reduction in behavioral health, inpatient behavioral health admissions, and a 6% reduction in ER. I think that the bottom line here is our member outcomes that we could actually measure for the people that were impacted by these terminations improved. Their health outcomes got better. And that's our goal. That is our objective. It's for our members to live the healthiest lives we can. And so I would say it was a success. And, I know we've talked about providers and giving them the opportunity to come back on. And, providers can always reach out and talk to us about joining our network. If we have a need, if we think we have a gap, or if we think there's a partnership that we can create with that provider, we'll pursue it. But it is our right as, the contract holder to have them participate or not. It's part of the managed care business.
Okay, does anybody have any questions for Ms. Reynolds? Could you characterize how you work with the school systems? There's one major school system I'm aware of that had a single contract with one TDD provider, yes. And it was for 53 schools, so it wasn't a small area.
Yeah.
And how do you interact with that, and how has managed care changed that relationship?
That's a very interesting circumstance, Delegate Sickles. It's very interesting that the school system contracts with the provider for services that the school doesn't cover. So they're not at financial risk for these services, but they have the relationship with the provider. And I can't remember if it was the school system, but there were situations where we could not term providers that we may have desired to because they had exclusive relationships with those school systems. That continues to be a problem, and it continues to be something we want to, work on. I think DMAS, will partner with us as we try to, find solutions for this, because it's a tough dynamic when the schools really own that relationship and then we have no choice but to contract with their exclusive providers. It's not ideal.
Okay, any other questions? Well, thank you. I hope you'll stick around.
Absolutely.
We might have some more questions for you as we go along. Okay, Tamika Smith, who's the CEO of United Healthcare. I think okay, please.
Hi, good afternoon.
Welcome back.
How's everyone? Again, I'll state my name, Tamika Smith. I am the CEO for the Virginia Community Health Plan at United Healthcare. I'm also a former Medicaid beneficiary, so the work that I do every day, this is really personal to me. Again, I like to tell people I've been on the other side of the coin, so I know what it feels like to be on the receiving end of Medicaid. But I also too think that it helps me stay grounded in the work that I'm doing on a day-to-day basis. What I wanted to share with this committee today was how this all comes together. From a managed care perspective, how we partner with DMAS and we partner with providers, how we work with members to improve member outcomes, hoping that we can also too reduce healthcare costs for the Commonwealth. And so there's what's called a quadruple aim, and I'll talk about that a little bit later. But as part of our obligation to our members, we live out our commitment to the Commonwealth via our partnership with DMAS, and we take pride in living out DMAS's mission and values. They have become, as an MCO, they have become our own. So service, collaboration, trust, adaptability, and problem solving are things that we have to do on a day-to-day basis in order to make this all work. The best way for me to demonstrate this commitment is to share a real member story with you all. And this is just one of many, but it's one that's top of mind because it's recent. Recently came through my inbox and was appropriate for this discussion today. As a managed care organization, we are uniquely put in a position where we have a 360-degree view of a member's full picture, right? We can see their medical records, their behavioral health records. We can see assessments that DMAS mandates and requires that we pull and put together for every member. We're also too able to see if there are social determinant of health factors that are associated with that member if the member has a need. So through technology and partnership, communication, and collaboration with one another, be it the providers, be it with the MCOs. Jenny and I have to work together a lot. We have to work with DMAS. I'll tell a really quick story, and this is just, this is real time, real work. I received a call on a Saturday from Tammy Whitlock because a member was in need of a medication. They were stuck at a pharmacy and were having some struggles. Well, the engagement and the level of involvement that we are with one another, she texted me on a weekend. I texted my staff. Through a number of phone calls and conversations, we were able to get that member the care that they needed that weekend. And so that's the level of engagement and involvement that we have with one another. And it's something like I've never seen, quite honestly. So this is the very first place that I've seen that type of rapport, engagement, and collaboration. But this particular member that I want to share with you, the story that I want to share is we have a current member of ours that had over 66 emergency room visits in 12 months. So you imagine they are using the emergency room as often as we're using the supermarket, right? And that drives healthcare costs up. This particular member had issues related to chronic pain, would get very controversial and demanding if her needs weren't met. She was addicted to narcotics, and we had to assist in her, her pain management. This member would get extraordinarily combative when she was walking into the emergency room department. And I share that with you because you think about how big a hospital system is. For them to recognize a member that comes that frequently, right, and then to reach out to an MCO managed care organization and share that with us, they can only do that if we have a relationship, right, and if we're talking to one another. So we've seen this woman's health go it's sporadic, it's up and it's down. But at the base of it all is we've got care managers that are at the hospital. We've got care managers that are at our organization. We've got individuals that are at the provider offices that are providing the same support. With this particular member, what we wanted to do, someone came up with the bright idea that we wanted to hold this member accountable and make her sign a contract, right? Because she was going to one provider and saying one thing, going to another provider and saying one thing, getting different medications, right? And in order for us to keep track of that and to help this member, they had this member sign what's, a safety plan in writing. All of her providers, her neurologist, her PCP, emergency room physicians, and we originally thought that it was going to be a problem with as big as a hospital is, that they wouldn't be able to manage it. Well, not only did she sign it, but now she's seeing her PCP on a regular basis. She's going to her neurologist. And over the last 3 months, she's only been to the emergency room department 4 times. And so it's this collaboration with providers that we choose to have in our networks because we know that they care. At the end of the day, members want us to know them, show them that we care, help them, and make it easy. And the example that I just shared with you, all of us coming together, we did exactly that. I'm pretty proud of that work and happy to share that story with you. I do want to read verbatim some of the notes that show up in our systems, right? So we talk about technology and how we're able to share data and information. So this message came through to one of our care coordinators, and this was from the care coordinator at the hospital. And she said, "Hey guys, just wanted to reach out and let you know that, to let you both know, since our mutual patient was in the ED yesterday for the first time, we got her to sign the safety plan. She came in with abdominal pain and nausea. The doctor and RN adhered to a safety plan that you put into place the entire time. We gave her medications per the pharmacy's recommendation." So again, collaborating with the pharmacy, everyone was on the same page. Even though she came in and tested positive for cocaine and marijuana, because those are her demons and that's what she's dealing with, the nurse then said the patient had been to a follow-up appointment that Tuesday, had a PCP appointment scheduled at the end of the month, and she said, "Thank you all for all of your help. The patient has become more cooperative and has started to engage medical resources in the community." And so that's a good story about how we all come together to make it all work. Consistent with DMAS's values, success in caring for the member requires system collaboration, problem solving, service customization. We literally had to customize service for that member, and that happens all the time. We talk about the 1.8 million members. Some don't access the service or the benefit, but others do, right? And sometimes those are the ones that we have to pull in close and make sure that we're putting our arms around them. Last I would say about that particular example is when we collaborate with the right providers at the right time, in this particular instance, we decrease the frustration that the provider had with the member and with the MCO because they view that as one of our members. And that's what we refer to as the quadruple aim. So it's for us to enhance the patient experience, improve population health, reduce costs, which we were doing with those emergency room visits, and then improve the work life of the providers. When that happens, magic happens. And we want to see that magic happen more times than not. Given that there's a disproportionate amount of the Commonwealth's Medicaid members that are Black, again, I talk about how personal this work is to me. There are a number of social determinants of health factors that not only are present, but they're material, and they require us to be unique circumstances within the community. The efforts to help improve the quality of care to Medicaid members, reduce healthcare costs, and help MCOs deliver on our promise to improve health for the Commonwealth's most vulnerable citizens is more important than it ever was, right? We think about the impact that COVID has had on our communities. It's wreaked havoc, but we are collaborating and partnering for all the right reasons. Last I will say is, as a former Medicaid beneficiary, I'm proud of the program. I'm proud of the model of care. I stand alongside DMAS in what they've put together. The service delivery, the outcomes, and the way in which we consistently drive and manage care efficiently and effectively it's notable. I'm coming from Colorado, so I can speak, I can compare. We partner with our providers that offer comprehensive services and whose patient outcomes are aligned with DMAS's and our own. Our collective efforts ensure that we offer adequate, which Jenny talked about, Cheryl talked about it, Tammy talked about it, but it's adequate quality access to care. We collaborate to meet our members' needs. We are held accountable for our actions, but we also too hold our partners accountable for their actions. We are diligent about reducing healthcare costs, and DMAS has a structure such that they make sure that we are reducing costs, and if not, we're penalized for that. So they're making sure that all of the right things are in the right places. I like to believe that what gets measured and managed gets done, and so they've got the right measurements and the right level of management to make sure that what we need to do for the citizens of the Commonwealth that qualify and are eligible for this benefit get what they need. Lastly, when managed care works, members, providers, MCOs, community service organizations, and the Commonwealth succeed together.
Thank you very much. Does anybody have any questions for Ms. Smith? It was very, very informative. And I hope you'll stick around as well.
I will.
Just in case we have time for we've got 35 minutes left. We could go longer. But with us today for the provider perspective, and before we go to public comments, is Mindy Carlin, who's Executive Director of the Virginia Association of Community-Based Providers.
Thank you, Mr.
Welcome, Ms. Carlin.
Thank
Good
you,
to see you.
Thank you. Mr. Chairman, members of the committee, I am Mindy Carlin, Executive Director of the Virginia Association of Community-Based Providers. I recognize the time for my remarks ended about 5 minutes ago, so
we've got time.
I'll do my best.
We've got 35 minutes.
To speed through. So first of all, thank you for inviting me to be here to speak on behalf of the members that I represent. I also want to acknowledge that Jennifer Fedora represents VNPP. Jennifer Faison is here as well, who represents the CSB. So I can give you some perspective on my association, but want to acknowledge others as well who work with us. So a little quick background on who my association is. So the common thread for the members of our association is that they are all private sector providers. They all provide community-based Medicaid reimbursed services, but they may do other things as well. But I can say that all of our members have those kind of common themes. The members of our association range in size from small providers with fewer than 10 employees to very large ones with more than 500. They range from having just one physical location to having more than 50 and really kind of touch all corners of the Commonwealth. So in coming forward today, I thought I would share a little bit about how our association has kind of managed transitioning to managed care and kind of working in partnership with both the MCOs and with DMAS to ensure that transition is as smooth as possible. And so the information that I'm going to share today was gathered in support of the MCO resolution panel that I believe the General Assembly kind of directed DMAS to convene, and we're really grateful for the efforts that have happened through that. So our goals in collecting feedback from our members in preparation for that was to identify areas of concern by MCO, to determine kind of where some of the identified issues and challenges were trends versus isolated incidents, to identify those things within the managed care environment that were working well as those areas where improvement was needed, and then to use that feedback in support of developing possible solutions to address those. So some of the information I'll share was gathered earlier this year. The topics that we identified in the survey that we conducted of our members kind of were drawn from the feedback that had been collected over the last 3 years as managed care was implemented, and we also provided an opportunity to share other comments. And so this slide just shows kind of the range of the issues that our members have consistently been bringing forward as areas of concern, and you'll see they range from kind of broad issues including that it's challenging to resolve issues with an MCO when they arise, to very, very kind of small but recurrent issues like paperwork being lost. And all of this kind of, leads to kind of more and more challenges in working with the MCOs. So I'll start with what's working well based on the feedback from our members. So by and large, the feedback was that the MCOs are doing a good job as they are receiving service authorization requests and categorizing them as either urgent or non-urgent. And the reason why that's important is because there are different timelines involved in how they respond in ensuring that the Medicaid members receiving care in an appropriate period of time. And so compliance with NCQA, which is the regulating body, has been really good, was noted as being good. And I'll say that wasn't always the case. And so we really are appreciative of the work that the MCOs have done to really hear the providers on that point. In terms of at the individual MCO level, there were no significant issues with credentialing. Now, that doesn't mean we wouldn't welcome one credentialing process that all of the MCOs used, but by and large, that was not an area of concern. No significant issues with respect to the amount of time given to respond to requests. And in most cases, MCO staff are respectful in communicating with our members. There were isolated incidents, as you might always find. So with that, we're very grateful for all of those areas where the relationship is really good. Our members did identify a number of areas where we believe improvement is needed. And so I'll go through those really quickly. First of all, since the transition to managed care, and in particular when the MCOs assumed full risk, we have seen fewer units being authorized for shorter durations for services than what's recommended by the provider. And so as you all understand well, when a provider interacts with a member who is experiencing a challenge, they assess that person and they then submit a service authorization for the services that they believe that individual needs in order to address their needs. And so consistently across all of the Medicaid MCOs, with the exception of Aetna, we're seeing significant reductions in the number of units and the duration. And this is particularly challenging with respect to, in the case of MHSS, mental health skill building, intensive in-home, and TDT. And this is a challenge for a number of reasons with respect to when fewer units are authorized than recommended. That increases the administrative requirements on providers because they need to request a length of stay or continued service more frequently when they are being authorized at a shorter duration. The second factor that has been raised by our members is the manner in which the MCOs are considering the impacts of COVID on the Medicaid members and how that factors into how services are being authorized. There's concern that the experience, and we all have heard and read and maybe even some seen, the impacts that COVID is having on the mental health of individuals. And so there's concern that that is a factor that should be considered in authorizing services. We heard a lot about care coordinators within the MCOs and the really important role that the care coordinators play. By and large, our members who interact with care coordinators with the MCOs talk about those relationships in a really positive manner. The challenge that we have seen, however, where improvement is needed is the connectivity within an MCO between that care coordinator and the individual who's authorizing service. And the challenge there, and we've had many examples that demonstrate that a care coordinator will actually, in discussing a patient's need with one of our providers, will recommend, discuss certain things that then are not actually authorized by their own MCO. And so when I get to the solutions, we can talk more about kind of what we've proposed to help with that. Inconsistent and unclear business practices within the MCOs, that's both inconsistent within an MCO and between the MCOs was an identified challenge providers are facing. This again was found for all the MCOs except Aetna. A significant increase in administrative requirements with managed care was identified by our members, and again, this was identified for all the MCOs except Aetna and Optima. And then portal issues in understanding the different portals, how to use them, their functionality, their usability was identified as a challenge for all of the MCOs at some level. So next I'll go to potential solutions. So the approach of our association is, it's very easy for me to stand up here before you and complain about all the things that aren't working. But that doesn't get us to where we want to be. And our priorities are really shared between the providers, the MCOs, and DMAS, and I know all of you. So what we've tried to do is translate those challenges into proposed solutions, and have been very pleased to see some of these moving forward, primarily through DMAS, but with the MCOs as well. So first of all, provide clarity to both the MCOs and the providers regarding how the pandemic should be considered with respect to service authorizations. And some of this has happened or will happen with TDT training that I know is planned for tomorrow. But a lot of the challenges that we see is with a disconnect in understanding, where education is and commonality in kind of that understanding is something that can lead to better outcomes. And so with the impact of COVID on service authorizations is one such area. Joint training on the Medicaid services. What are the services? What is the eligibility? What is the medical necessity criteria? How is it intended to be delivered? This may sound crazy to you guys, but what my members often sense that the individuals who may be authorizing services have a different understanding of what the essence of that service is and how it should be provided. And so while we are in a transition of enhancing our services through Project Bravo, there is work that can happen now to increase that shared understanding. And as I referenced, DMAS has done that and is going to be doing that through a training on TDT specifically for providers and the MCOs tomorrow, and we're grateful for that. With this, however, we think it's really important that the same information be shared with providers, with care coordinators within the MCOs, and with the MCO service authorization decision makers. So we all kind of have that same place that we're coming from in understanding the services that are available today. In the same vein as education, training on clinical documentation for providers and for the MCOs so that there is a solid understanding of the expectations between DMAS, the MCOs, and providers when a service authorization is requested. Issue guidance clarifying. So the next kind of category moving beyond education is really in kind of the processes and the setup, because as I noted, we have 6 Medicaid MCOs and Magellan, and each MCO is unique and distinct in how they operate and what they require and their processes and their forms and the documentation requests. And so while we recognize the importance in order for managed care to work for the MCOs to have flexibility, we believe there is work to be done to really look at where standardization is not harmful to an MCO's ability to carry through their mission, but can simplify things and increase the efficiency between providers and credentialing. One credentialing process is an example of where that could happen, but really, better understanding those areas where there can be increased standardization across the MCOs. Next slide is forms, processes, business processes. Where can we really look at standardization so providers aren't having to kind of behave differently depending on the MCO who they're communicating with? So when we provided this feedback, I recognize you can't read this on the slide and you're really not intended to, but we provided this feedback following the survey of our members to DMAS kind of broadly and summarized as I just did, but also MCO by MCO feedback to identify the positives that we're seeing with a specific MCO, the areas that were more negative, and then the areas where feedback was kind of split. And the hope is that this can be helpful as we figure out ways to work well together. With respect to MCO networks and provider terminations, I wanted to share some comments on this as well. We've heard a lot about this today, and I want to express our understanding that network management is foundational with managed care. The MCOs need to be able to manage their network. That being said, we think there are some things that could be done to kind of improve the transparency, the communications surrounding how they manage their networks. And so first, some themes: increasing the transparency, recognizing the critical nature of patient choice, particularly to engaging in their own treatment, and how that is really important in leading to positive outcomes. Ensuring that the Medicaid provider network reflects the diversity of those that they serve, and how do we get there with that. And then providing a bit more oversight. And, you know, I learned some things today with respect to oversight on MCO network composition. We are aware of some of the other oversights. So, you know, really continuing to look at that. So, similar to kind of what I've talked about previously earlier today, we broke these down into some potential solutions to consider to improve the challenges we see. These recommendations include providing additional information about what each MCO identifies and evaluates in choosing who's in their network. Senator Hanger, you raised in your comments how you can't have no reason for eliminating a provider from your network, because there has to be a difference between a provider you choose to keep in your network and a provider you choose not to keep in your network. And our concerns are not about terminations with cause, not a concern. If a provider is not behaving in a way that they should, we would stand right with you in recommending they be terminated from your network. Our challenge is in the terminations without cause, which by and large, those are the terminations that happened when the MCOs assumed their risk. So back in 2019, the fall of 2019. And so from a provider perspective, how can a provider know how to improve, what to work toward in order to get back into that network, as Dr. Booker shared when she was standing up here? How can you know what to focus on to be asked to be included if you don't know why you were excluded in the first place? And so, again, our beef is not with the MCOs needing to be able to manage their networks. It's just increase the transparency, give providers something that they can work toward. Our second recommendation is to provide a process by which an MCO may provide feedback to a provider if they're going to be terminated. Because again, I get the makeup in terms of number of providers and capacity and network adequacy, but there is some reason why provider A may be excluded and not provider B, and just better understanding how to improve and work toward that is really important. Providing a process to enable providers that are terminated without cause to come back. I can say it's good to hear that that's always an option for providers, as we've had a number of our members seek to be reconsidered, only to be told that there's no way to proactively request that the MCO basically will let you know when we're interested in having you join. And so that's something I'd love to learn more about. And then providing, again, a bit more oversight, or maybe just understanding of the oversight that's happening, to ensure that the makeup of an MCO network really values patient choice, and that it reflects the diversity of those that it serves. We didn't talk much about MCO preferred provider networks. So several of the MCOs, I'm not sure if all of them have gold card programs or preferred provider networks. Many of our members are members of these preferred networks, which have kind of different requirements placed on them. So what we have asked for and continue to ask for is just a better understanding of, on the positive side, what an MCO is looking for in a preferred provider, so that, again, our members are aware and providers can kind of be working toward being included, or at least even being considered. There's not a lot of transparency around kind of what those preferred provider networks are and what they're not. So I have a couple slides on Project Bravo, but recognizing, and school-based services as well, Mr. Chairman, that I'm happy to talk through or not, but I want to be respectful of the time of the committee, and I'm happy to answer any questions folks might have.
Well, I would like to take some time, I don't know how the committee feels, to get some responses from both DMAS and from MCOs that are here to some of these suggestions. I think I know the answers to some of them. But does any, and some of this stuff, I'm so glad that you've been working well with them, because as you noted, there's improvements have been made, and a lot of this doesn't lend itself well to legislating. right? It lends itself well to working well with each other, which is hard to put in a bill.
Yeah.
So, but would anyone like to comment on this? Tammy?
And maybe, Mr. Chairman, before Tammy,
Or-
there were
or
a few
Cheryl.
comments that were made prior to when I spoke that I'd like to respond to
Oh,
as
please.
well.
Please do.
So with respect to the standard contract language of terminating with cause, and that being standard contract language that all the providers signed, that is true. But the alternative to not signing those contracts is that you wouldn't be in their network in the first place. So I just wanted that to be clear. There aren't negotiations with respect to that. I think it was you, Jenny, maybe, who mentioned the utilization numbers, right? And I think we all share priorities with respect to wanting to deliver the most efficient service to reduce costs, keep people out of the ERs, keep them out of residential treatment. But I contend that perhaps reducing utilization rates for community-based services is maybe not our goal to get there. Perhaps we shouldn't view lower utilization rates for community-based services as our goal, because it's community-based services that reduce those instances when a patient is in an ER, in a hospital, in a residential treatment, in jail, homeless. And so,
Yeah, let me
Right.
clarify that, because that
Okay.
was the point I made. The point was,
course, yeah.
we were
Ms.
reducing-
Reynolds?
Yes, oh, excuse me, Jenny Reynolds,
Yep.
Anthem. The point was, in fact, that, using these services appropriately, we found reductions in ER and inpatient. And so it was really those physical health outcomes that we saw improving as a result of better interventions on the behavioral side. So the goal was not, in fact, I think the stat I pointed out the most was the increase in the therapy services, and that was a win, because supporting those community health services with therapy helped contribute to those ER reductions. And so I do want to make that point. It's not our objective to decrease community services. It's our objective to get better outcomes overall. I think that's really important.
Ms. Smith? Okay. Okay, any question for these folks? But Tammy or Cheryl, do you, sorry for calling you by your first names, but did, Ms. Whitlock?
Call me anything that you would like. Not in public, maybe. Yeah, I'm not going to respond to that. I think that was fine, but I think you had asked about the recommendations that Mindy
Yep.
had made. And absolutely, we are always open. I think we have a great relationship, as Mindy said. The MCO resolution panel has opened a lot of eyes and doors and opportunities for us to communicate. But even outside of that, we are always open to sitting down and working through some of the recommendations.
Well, what is the probability of getting more standardization and a more uniform credentialing process?
Credentialing, go ahead.
I have to clarify the word credentialing and contracting.
Yeah. That's two
Credentialing
different things.
is standardized. It's to contracting.
Right.
And what I guess I'm trying to ask is it that you would want the same contract for each provider type? I guess I think that's something we would have to talk about when I hear the term, because it's not the credentialing, it is the contracting. And each plan does, because some plans are national plans, and they have different contracts versus the regionals. So those are unique, and I think we do want that uniqueness from each plan. So I think what we can do is, and I agree with Tammy, that when we have our work group discussions, we can talk about particularly what is it that they are concerned about in that process. And so that's a reasonable question. But contracting, all plans are using the same contracting flows. That's not the issue. I think the real issue is contracting and what happens there. And also what you said, where can you have negotiation power and where don't you? And that's a different discussion. But I think that can be done in your group.
Thank you, Ms. Roberts. Anybody on the dais here have a question? I want, Delegate Hayes.
Very quick, Mr. Chairman. I'm just interested in knowing, because we all are in this pursuit for better care for people in the community. And so I'm interested in knowing, as we have these processes where we actually discontinue certain I guess, providers. Tracking that, and ultimately, well, for one, Mr. Chairman, you mentioned something about the demographics of those members, that we need a process to try to track that a little bit better as well. But ultimately, the individuals in the community, are we tracking their health care, their participation once we have shifted and changed or dropped who it was that they were engaged with already? Because sometimes it's about relationships. And so if those relationships have been developed and someone is finally on track to a better health care process comprehensively, and then that changes or switches, then there may not be the same levels of trust with a brand new provider.
Yeah, and this is Jenny Reynolds. I think that's what I tried to demonstrate when I showed some of those outcome statistics. You know, those were statistics driven by members that were impacted by those network changes. So truly following the outcomes, you know, after we made some of those network changes. And two, you know, providing the members the ability to change MCOs if they wanted to stay with that provider that maybe Anthem didn't want in their network anymore, but 2 other MCOs retained in their network. They had the opportunity to keep that relationship and go with that provider. I will say in our TDT space, and it was a note on my slide I didn't mention, 93% of our members stayed within Anthem, and you know were satisfied with the network that we ended with that, you know, served their needs. So we didn't see much shift to other networks, but it was their option.
Okay. Mindy, do you have?
Sure.
So,
Mr. Chairman, thank you. And my comment on that would simply be, I'm sure I'm not the only one who has kind of experienced phone calls with my commercial insurance and kind of the complexity sometimes that can be around communicating with insurance companies. And so I just remind folks that the population we're talking about here are people with serious mental illness. And so what may seem simple to you or me to, oh, I'm just going to switch my provider, and who do I call to do that, and then what happens? In some cases, my members have shared examples where the individual they serve finds out that their provider's been terminated before the provider, or, you know, the timing of kind of how that happens can be really overwhelming for a Medicaid member who is seriously mental ill and having treatment. And it's not a perfect process, right? It's not, and there is no perfect answer. I just suggest, again, I think that continuing to work together and talk and collaborate is really important. Okay. And we're all going to have our horror stories. It was hard for me to look at Ms. Reynolds' list of all the provider horror stories, but that being said, I could give you the same slide with MCO horror stories. And so, you know, I'm really grateful for the opportunity for us all to be here together with DMAS, moving in a positive direction to figure out how we can work better together, recognizing there always are going to be bad apples. So
terrific.
Yeah.
So, yeah.
Can I make one clarifying comment?
We need to leave some time for the public. If there's anyone in the public who would like to speak, please come up and line up behind Ms. Reynolds.
I do just want to clarify, because this is really important. With the seriously mental ill, that's a different risk stratification, and our members that are stratified as SMI members, they receive a much more stringent care coordination.
It's not TDT.
And so, yeah, this is not your CMHRS
Right.
services. I think that's important too.
So I don't see anyone coming up to testify, but I would like, Delegate Price.
I was not sure if I was public or not. Thank you, Mr.
Very
Chairman.
public. We pay a lot of attention.
I definitely wanted to just thank the committee. I know a few of us had resolutions that ended up in why this conversation happens. I wanted to bring a voice that maybe was not explicitly reflected here, and that was of the constituents I've heard from, the actual members or patients. And anecdotally, what I am hearing is that between Senator and me, we're hearing that Black and Korean patients are not able to find providers of choice. And we are hearing from providers that are Black and Korean, and at very large numbers, that anecdotally feel that the terminations landed in a lot of minority providers. Now, I saw the slides. Lots went into the slides. And so what I'm not saying is that there was an intent. But as legislators, if there was an outcome such that it is impacting business owners, members, quality of care, that's where I would like for us to spend some time so we know if any of the solutions, continuing the conversation. So that's what really got me here. And then just trying to, it's not new for me to be in a conversation that seems sometimes adversarial, but I do know that there's like a balance to be stricken. So I would love to be a part of conversations going on. I know that Delegate Bell had conversations that he wanted to have about TDT. I'm not sure if all of his questions got answered, but I also know that we had other folks that wanted to speak up for themselves. I do not think that you have to have significant mental illness in order to find navigating your insurance company hard. I can say that, for myself, and I'm not even trying to, be funny, but just a lot of the folks that we were hearing did not know that they had the choice, did not know that they could advocate for themselves in order to keep the provider that they had built the relationship with. So I'm actually hoping that this is the beginning of a conversation for this committee and not the end, so that we can allow for some folks to send you all some emails as they're actually watching the storm coming our way back in Hampton Roads.
Thank you so much. This subject area has been something that I've been interested in for a long time now, prior to the last session and the bills that were put in, because of, especially when we became one of 23 states to take care of our most fragile population and nursing home population with managed care. I mean, more than half the states don't do that. So there's a reason they do it the way they do it. But, I mean, we've had some good positive results, and I think everybody's learned a little bit today. We're going to learn some more about this, and I wanted to tell everybody that Senator Creed Deeds has been listening this whole time. And he wanted to let you know that, and he is a very active member of this subcommittee and has questions of his own that he's going to take up with the various speakers. But I wanted to ask Mr. Tweedy and Ms. Mastert if they had any questions, because they're our experts that we depend on to get it right here. It's hard to put you on the spot, but here's your chance. You got 4 minutes.
We'll pass on this one, I think.
Okay, you'll do like Senator Deeds, same thing. Follow up.
But I would point out to you, Mr. Chairman, that Delegate Jones and Delegate Brewer and Delegate Bell are on the phone.
I mentioned that earlier. I mentioned that at the outset. We do need to take up a motion here on this last business on the, we need to discuss a request for the JLARC study of Behavioral Health Office of Licensing. Could you explain that to what we need to do here, Ms. Massar?
Certainly. This came up from Delegate Carr. We had a little bit of discussion about it at the last meeting. And Mike and I both met with some member of the public to discuss it in a little bit more detail. Evidently, there are a number of elements in the code that give the Department of Behavioral Health and Developmental Services some of the tools that they need to, in their licensing office to monitor, place limitations, revoke, suspend, or refuse to grant a license to providers of persons with mental illness, substance use disorder, or developmental disabilities. I think there's some feeling in the provider community that they don't appear to be using those tools effectively, and that there could be room for improvement, and that instead of using those tools that are allowed to them by statute and regulation, they write more rules, sort of more informal rules of what the providers have to go through, and it becomes very administratively burdensome on those providers. So, and that, this kind of thing that they're doing sort of drives the staffing in that office. We've put in a lot of staffing over the years to comply with the DOJ settlement and for the growth in providers. And so there was, I think Delegate Carr is requesting that JLARC take a look at the DBHDS Office of Licensing and just go through the whole process of looking at how they apply their standards, how they follow the code and regulations related to those, how they use those tools that are available to them, and when they deviate for that, what kind of a burden that provides to the providers, and some of the other barriers that are encountered by those providers. So Delegate Carr wanted to request JLARC to go ahead and take a look at that with some recommendations specific about the use of alternatives and the tools that they have available to them. And I think I remember mentioning to you the last time that you met that Hal said that they might have a little bit of room on their dance card for anything that you're interested in.
Okay. Anybody have questions for Ms. Massart?
Move that we make this request.
Second.
It's been moved and seconded that we pass this request on to JLARC to study. All in favor, say aye. Can we take a voice vote on this? Do we need a recorded vote? Okay, all in favor, say aye.
Aye.
Any opposed? Okay, very good. Very good, thanks. This has been a good hearing, as I said earlier. It's brought up a few questions, more questions that, and maybe when our next meeting, we can go a little bit deeper on some of this stuff. But Susan, do you have something you want to say?
Yeah, I think the one last point that Mike and I would try and like to get also on your dance cards would be a date for a September meeting and an October meeting. So if, and we'll send something out ASAP, but we'd like you to look at entertaining a meeting that would fall on either a day in September or October that the House Appropriations Committee meets, or a day that the Senate Finance and Appropriations Committee meets, so that we can tag team it there to make it easier since it has to be in person.
I would just
Senator Howe.
mention that in September, Senate Finance and Appropriations will be in far southwest.
Oh. Okay. So that leaves our time, which is, do we have a date on that? We do not have a date.
I want to say it's around the 15th or the 18th, but let me double check.
Ms. Whitlock, can you come to the podium just a second more, since I got a minute? All right, we can go up, I'm over. Can you tell us about the process of renewing the MCOs in the merger? Talk a little bit about the merger between Medallion and CCC Plus. You discussed this, but what's the timeline for that? And do you think number 6 is the right number to have? Has that been a good number for Virginia? Are we going to try to expand the number of MCOs in the next round when we merge the two into Cardinal Care?
That's a loaded question. The time frame for the merger of the contracts and thus the programs is 7/1/22. So we are on track to do that. Each program has a base contract, and we were just talking about it this morning. I think both of our base years for the contract would be over in 23, correct, Cheryl? So 2023. We also have option years to renew after the base year. So 2023 would be, I guess, I mean, unless we were instructed otherwise, I guess, the year that we would be earliest to repure.
Okay.
I mean, it depends on how many plans bid and what the proposals look like. It's really, what the field looks like when we get it.
Okay.
Yeah.
Terrific. Thank you so much.
Thank you.
And if there's no objection, okay, appropriations meeting September 20th, Senators. Is that okay with you? September 20th?
Do you know, Mike, when you're coming back? I don't know.
We need the 21st and that's from where by Southwest. Okay. In September, and we're talking about having a subcommittee meeting on the 20th.
I'll go on the calendar the 13th.
Yeah, it's a week earlier.
The 20th might work.
The 20th?
We'll just send out the email.
Okay. Okay, we'll be checking with everybody. The 20th could be a date, public. Okay, without objection, we will adjourn. Thank you very much.